Welcome to the final session of the core MedFlight ultrasound curriculum. Today we're going to talk about what I think are the most exciting pieces of resuscitative ultrasound, which is thoracic or cardiopulmonary ultrasound. This is a huge topic with a lot of novel work still ongoing, and I encourage you to read and watch additional resources on this topic, some of which are linked here. For the purposes of getting started on MedFlight, we'll break this talk into two parts in order to cover four seemingly simple questions. For the lungs, we'll ask, is there a pneumothorax? And are the lungs filled with something dense instead of light, fluffy air? For the heart, we'll ask, is there a pericardial effusion? And what do I do in cardiac arrest? Which really applies to any critically ill peri-arrest patient. So let's get started with the lungs. We'll start by talking about some background concepts, then the scanning technique itself, and then some pearls and pitfalls of this particular scan to prevent you from falling flat on your face. Let's start with the background. Lung ultrasound is different from exams looking at free fluid we discussed last time. When you do a FAST looking for free fluid, you'll see the organs bouncing off sound in a very predictable manner, making them look a lot like those organs do in real life. So a kidney kind of looks like a kidney. With lung ultrasound though, sound bounces in an air-filled bellows. This produces a ton of artifacts that we'll talk about because sound doesn't move predictably in air the way it does in fluid. Interpretation of lung ultrasound relies on analyzing and understanding these lung artifacts. So when you first put the probe on the patient's chest, here's what you'll see. On either side, there are dense shadowing ribs, seen here, with a pleural line running just below the ribs, which represents both the visceral and parietal pleural layers rubbing against each other. Normally, when the visceral and parietal pleura are touching in a normally inflated lung, you'll see a shimmering movement of the pleural line as the two layers slide by each other during the respiratory cycle. On the other hand, if a lung has collapsed due to a pneumothorax, like you see in the animation here, the two layers aren't touching anymore because there's air in between, and you'll no longer see that sliding movement. The second basic concept to understand is that air will rise to the top. This is a big reason why trauma supine x-rays are often useless. Here's an example of a relatively normal appearing chest x-ray, and here's the CT scan on that same patient. Time and time again, we've found that the sensitivity of these chest x-rays is quite lousy, somewhere around 40%. By contrast, the presence or absence of lung sliding can rule the pneumothorax out with 79% sensitivity. So now, let's synthesize these two basic concepts into a formalized scanning technique. There's significant debate about which probe to use. Recall that high-frequency linear probes have very good resolution at superficial depth, and as a result, many folks prefer to use this probe for pneumothorax detection. Nevertheless, a number of groups, including in the pre-hospital world, have found that curvilinear and phased array probes have adequate performance. We'll start by showing the images obtained with a linear probe, and then discuss how this can also be achieved with our MedFlight phased array probe. First, you'll use the concept that air rises and position the probe on the highest point on the patient's chest, with the indicator pointed towards the head. Visualizing lung sliding in this region virtually rules out pneumothorax and you can move on. However, since many of our patients have significant soft tissue, you should also slide the probe up and down a rib space to make sure you're not missing a smaller pneumothorax in the anterior chest. Occasionally, especially in the beginning, you might be unsure if you're seeing sliding or not. In this case, you can use something called M, or motion mode. This will allow you to track movement of just one minuscule plane over time. In normal lungs, seen here on the left, you can see that below the sliding pleura, which is being traced over time here, the movement creates a heterogeneous appearance, and this pattern is often called a sand on the beach pattern, because the lung parenchyma is obstructed by the sliding pleura. On the other hand, if you see an organized linear appearance distal to the sliding pleura, often called the barcode sign, this is very concerning for a pneumothorax because this represents absence of sliding. Remember, sand on the beach, time to relax, barcode sign, time to pay up. Now, there are a lot of other reasons other than a pneumo that can cause absent lung sliding. Many of these has to do with absent or diminished air movement, such as obstructive lung disease, main step tube, or apnea. But obviously, you probably shouldn't use ultrasound to detect apnea. How can you differentiate between these other causes of diminished air movement and a true pneumo? Once again, remember that the pneumothorax will rise. This means that there will often be a point where the pleura once again reattaches, and you can easily find this point by sliding the probe posteriorly on the patient's chest to get to the more dependent portions of the chest wall. When you do this in a patient with a pneumothorax, you'll find that lung point, which will show an area of sliding dependently next to the area of no sliding. This is highly specific for a pneumothorax. Some reports have even claimed 100% specificity in the right patient population, but we'll talk in a little bit about some pitfalls to assuming that's the case. First, let's summarize the scanning technique. Start with the highest place in the chest, slide up and down to find a spot with a pneumothorax, and when you find it, slide down until you see a lung point. That's pretty much the gist of it. So what are these points that you can get tripped up on? What are these pearls and pitfalls? The first one to think about is subcutaneous emphysema. Remember that ultrasound doesn't go very well through air, and when you have subcutaneous emphysema, which often accompanies a significant traumatic pneumo, this can make ultrasound very difficult. Here's an example. What you're seeing here is something that looks like the pleural line, outlined in blue in a second, but notice at the end of the clip that this lies above the rib. This is actually the subcutaneous air mimicking a pleural line. This is one reason it's so important to start with a sagittal orientation, in order to make sure that the rib is in your field of view and what you think is pleura actually lies below the ribs in the appropriate space. Unfortunately, this will make your ultrasound useless, though the good news is that if this person is unstable, they will often need a chest tube since they are very likely to have a pneumo with their subcu emphysema. Next is something called a lung pulse. This is where the pleura moves at the same rate as the patient's heart rate rather than the respiratory rate. It's more often seen on the left side because that's where the heart is, and in abnormally inflated lungs. Fortunately, the reason this occurs is that the heart's pulsations are transmitted through the lungs to the visceral and then the parietal pleura. This means that the two layers of pleura are touching, and this also will rule out a pneumothorax. Now, the biggest pitfalls have to do with this assertion that the lung point is 100% specific for pneumothorax. While this is true in studies looking at the appropriate clinical context, there are a number of things that can throw you off. The first is that the lungs can also be adjacent to other non-sliding organs, such as the heart or the diaphragm. And if you aren't cognizant of where your probe is positioned anatomically, you may be fooled by this interface. So pay attention to where your probe is physically. You should also realize that if the pneumo causes complete circumferential separation of the pleural lining, you won't see a lung point. The silver lining here is that those patients usually have those more classic findings of tension pneumothorax, like mediastinal or airway shift and jugular venous distension, making it much easier to justify empiric decompression. Finally, there are other lung features which can cause focal absence of lung sliding, such as Bleb's adhesion and pleurodesis. How do you get around these? First, make sure that the lung point makes sense and that the lung point is actually dependent. Posterior Bleb's might look like a lung point, but it will look backwards. The sliding will be more anterior, and the dependent portion will be where the air is. Now, what about more pesky anterior Blebs? If you're less worried about the spine, you can certainly sit the patient upright to see if the pneumo, and consequently the lung point, will move to a more antidependent region, which a stuck-on Bleb or pleurodesis adhesion will not. However, there are also some lung artifacts that you need to know about, which can also tell you if the pleura are touching, and more importantly, can tell you if the lung parenchyma is too dense with fluid and inflammation, which suggests that you can harm your patient by giving too much fluid too fast. The first artifact you'll often see produces horizontal lines called A-lines. This is essentially a reverberation artifact. In this case, the sound will bounce off of a reflective pleural line and then hit the chest wall, where it will get reflected back to the pleural line and become trapped in this vicious reverberation cycle, going back and forth within that chest wall space, occasionally making it back to the transducer at regular time intervals. These time intervals are interpreted by the machine as depth, and you will see these regularly spaced A-lines. This can be seen in normal and dry lungs, but even more common in hyperinflated lungs of patients with COPD or vented patients getting a lot of autopeep. This artifact, unfortunately, arises only from the parietal pleura, and so tells you nothing about whether the two layers are touching, so it can be seen in pneumothorax as well. Here's a good example showing A-lines persisting at the lung point on both sides of the lung point. So on the left is the lung point here, and on the right is an area of no sliding. Now, as the lungs get a bit more dense, they will often produce little vertical reverberation artifacts in the area of density called Z-lines. These areas of density are typically normal structures like interlobular septa, and so these vertical comet tails only go to a few centimeters in depth. These are normal, and because they are visualizing lung parenchyma, necessarily mean that the pleura are touching and will also exclude a pneumothorax. Here's that earlier view I showed you with those little comet tails going down just a couple of centimeters and kind of disappearing pretty quickly. The last artifact to talk about are B-lines. B-lines represent confluent areas of density and look like long comet tails that go all the way down to the bottom of the screen, even at higher depths. Typically, you need to be at least 13 to 15 centimeters deep to make sure that B-lines are going all the way down and aren't just long Z-lines. These findings are found in very dense lungs, such as those seen in patients with pulmonary edema, ARDS, or focal infiltrates like pneumonia. These lines also originate from the visceral pleura and exclude a pneumothorax. Remember, when you see B-lines, be very careful about volume resuscitation of these patients. These patients are typically volume overloaded with a very tenuous respiratory physiology, and you need to be very careful about overloading them with more volume. They don't, however, have a pneumothorax, so please don't decompress these patients. Let's summarize this portion. A-lines can be present in pneumothorax or no pneumothorax, so they don't tell you anything about the presence of a pneumothorax. However, B and Z lines will both rule out a pneumothorax, and B lines will typically represent very dense and volume tenuous patients. Once again, summarizing the scanning technique, start at the anterior chest, go up and down to find an area of no lung sliding, and if you see this, go down in order to find a lung point. Remember that pneumothorax should really be suspected in patients with no lung sliding, with a lung point, and make sure that that lung point obeys gravity. Pneumothorax is ruled out if there is lung sliding, if there is a lung pulse, or if there are any of those visceral pleural artifacts like B or Z lines. So far I've been showing you these beautiful pictures of the pleural line with the linear probe, but what will they look like with our phased array probe? Most of the time, you will be able to see sliding reasonably well just by putting the probe in the same location. Note that the gain here is quite low to make sure that you aren't overexposing the pleural line and can actually visualize that sliding. So the first key with the phased array probe is to minimize your gain. Now if you're still unsure, the next thing to try is to decrease the depth, so that you're focusing in on the pleural line rather than wasting all that deep underexposed space. So here's that same patient, focused in a little bit more with lower depth. So that's step 2. Minimize the depth so that you're focusing in on the pleural line. Now occasionally, especially in very thin patients, the probe will have a hard time focusing on that very superficial pleural line. Recall that we've been doing most of our exams in the fast mode when you first turn on the machine. However, you can go to the upper left-hand menu here and select lung for the lung exam. And this setting will help you better visualize the pleural line and can help confirm sliding. So that is step 3. Go to the lung setting. Now notice here that occasionally that lung sliding stops and then comes back. What's that all about? Here's another example. Sometimes it looks like they're sliding, and sometimes it looks completely still. What this is the patient taking a breath in and out. So remember to ask your patient to breathe when you're looking for air movement, because if they're not breathing, there's no air movement. If they're vented, look while you're giving them a breath. Finally, our machines do allow for M mode, and you can always fall back on this to really confirm that there is or isn't pleural sliding. So to recap how we're going to do this with our phased array probe, minimize your gain and your depth, use the lung setting, remember to ask the patient to breathe, and when in doubt, go back to M mode. For the time being, we'll continue using only the phased array probe. If this isn't working out for us though, we'll definitely readdress and consider getting a separate linear probe. So keep your feedback coming. Here's a few resources for you to review. Alright, let's get to the fun part. The last piece of this talk is about looking at the heart. Obviously, echocardiography is a complex field, but today we will talk about 2 key pieces of the emergency echo, identifying and interpreting pericardial fluid, and knowing what to do with those cardiac views during cardiac arrest, which, as you will see, actually applies to any peri-arrest sick patient as well. There are a lot of other components of the critical care echo which we'll only briefly touch on today, but we'll plan on exploring in more depth once everyone is on board with the basics. Today, we will talk about just one view of the heart, called the subxiphoid view. In this view, the transducer is placed just below the xiphoid process and aimed up into the chest, which will often involve a pretty flat angle relative to the torso. You will see this image with the liver in the near field, followed by the right ventricle and atrium, and then the left heart sitting at the deeper side of the far field. You can now observe the synchronous contraction and valve movements of the cardiac cycle. The first thing to look for is a stripe of black fluid in front of the heart, which represents fluid around the heart. Here it is outlined. Remember that just like with abdominal fluid, free fluid in the setting of trauma, especially penetrating trauma, should be presumed to be blood. But in the setting of a medical patient, this can be uremic, infectious, malignant, inflammatory, any number of things which may change your management. Once you've identified the free fluid, take a close look at the right ventricular free wall closest to the near field and watch for collapse of the RV during diastole, which represents impending obstructive shock due to tamponade. Here, you really don't see very much RV collapse, but here's an example of early tamponade. Note the bowing of the ventricular free wall just at the end of diastole. This is sometimes referred to as a trampoline sign because it looks like someone is bouncing on top of the right ventricle. Here's a more obvious video. Here, the RV is almost fully collapsing at the end of diastole. One thing to be aware of is that the presence or absence of tamponade does not depend very much on size, but rather on the rate at which the fluid is accumulating and the pericardial sac is able to stretch to accommodate that fluid. So a medical patient might have a very large effusion and be fine, but a trauma patient might have a relatively small effusion, like the one seen here, and be in hemodynamic collapse. So that's what's important to know right now about effusions and tamponade. But now let's talk about the meat and potatoes. What do we do with the all or mostly dead patient?
He's dead, he can't talk.
Ooh, look who knows so much, huh? Well, it just so happens that your friend here is only mostly dead. There's a big difference between mostly dead and all dead. Please open his mouth. Now, mostly dead is slightly alive. Now, all dead, well, with all dead, there's usually only one thing that you can do.
What's that?
Go through his clothes and look for loose change.
Alright, so primitive ambu bag aside, what do we do in cardiac arrest? There's going to be 4 things that I want you to be looking for when you're ultrasounding a patient in cardiac arrest. First, ask yourself, is there cardiac activity? Next, ask yourself, what is the mechanical rate? And what is the mechanical rhythm as compared to the electrical rhythm? And finally, ask what the function is. How well is that mechanical pump doing? Let's start by defining cardiac activity. This has long been a focus of debate because it used to be defined the way Judge Stewart defined pornography. Oh, you'll know it when you see it. We now know that if you use such a loose definition, there's a lot of disagreement, which definitely is not good when you're in literally a life or death situation. So based on several recent studies, we'll now define cardiac activity as this: myocardial contraction, meaning the myocardium is contracting and those ventricles are getting smaller, that black is getting smaller. And this needs to be enough to produce forward flow, rather than just movement of blood in the chambers or isolated asynchronous valve flicker. Here's the obvious example of good cardiac activity that we looked at earlier. And here's another example. I swear, this video is playing. This is clearly no cardiac activity. There's no movement of anything in this heart. Now here's an excellent example demonstrating the absence of forward flow. When you use IV fluids or meds and pushing them very fast in a coding patient, you'll often introduce little air bubbles. This can help visualize the absence of any transit through the heart, despite some occasional isolated flickering valve movements. This also represents an absence of forward flow, and so doesn't meet our definition of cardiac activity. Here's an example of a common fake-out. This is the same patient as in the first example, but it almost looked like something is now happening. What is it? This is what happens when somebody is squeezing the ambu bag and inflating the patient's lungs. This squeezes the heart from the outside and produces isolated valve flutter, but it is not myocardial activity. Cool. So we define cardiac activity. what do we do with this information? Remember that one bit from Nightmare Before Christmas?
Interesting reaction. But what does it mean?
Spooky, right? What to do with this information came into a bit of very blurry focus last year with a massive publication of what is now known as the Reason Trial. This was an observational, prospective, but protocol-driven study. The authors looked at the echoes of 793 patients in PEA or asystole in their emergency departments all over the country. And by protocol, the participants had to continue CPR for at least one cycle after performing the ultrasound. They found that positive activity definitely had a strong correlation with survival to hospital discharge, with an odds ratio of 5.7, which is excellent since we all kind of presume that a beating heart is much better to have than a non-beating heart. But, and here's the kicker, 3 patients with this ultrasound made it to hospital discharge neurologically intact. Who were these 3 patients? There was a 64-year-old man who was found by EMS and VFib, shocked into asystole, and had a 40-minute emergency department resus, walked out of the hospital neurologically intact. There's a 67-year-old man found in VFib, shocked, PEA, 6 minutes ED resuscitation, walked out of the hospital neurologically intact. And finally, here's a weirdo, 75-year-old woman found in her bed in asystole with an unknown downtime, resuscitated for 20 minutes in the field and then another 10 minutes in the ED, made out of the hospital neurologically intact. Here's what I said when I heard this.
What?
So, what? Let's listen up here for a second. First, this trial did show something we've all suspected and have relied on in our resuscitation. It definitely showed that cardiac standstill is very bad. It just asks us not to rely on this alone and use the rest of the clinical picture to guide management. And we'll talk in a moment about how to delay the decision to stop the code while you synthesize that same clinical data. We also learned from the Reason Trial and some of its post hoc analysis that when ultrasound is used to guide resuscitations, you can get markedly improved results. So how can you use ultrasound to help guide your management? This is where those other features come into play. First, look at the mechanical heart rate. As we'll discuss next, this is not necessarily the same as the electrical rate you see on the monitor. Here, the heart is pumping okay. It's just only doing it once every 5 to 6 seconds or so. You should manage these patients the way you would any other bradycardic patient. Depending on what you think is causing it, you can use an epi drip, you can use atropine or pacing, but you could also consider other things like glucagon and insulin for beta blocker or calcium channel blocker overdose. Next, look at the rhythm. ACLS algorithms all rely on rhythm analysis to feed into a particular algorithm. This is great if all you can get is an electrical rhythm, but it turns out that the mechanical rhythm of the heart is actually much more helpful in guiding management. For example, here's the ACLS example of an asystole rhythm strip. However, when you put the probe on, this is what you see. This is actually a very fine ventricular fibrillation. You can see that as a little bag of worms, especially on that free right ventricular wall. This patient doesn't need more epi. This patient needs a shock. Here's another example. See that bag of worms? Shock. Here's another, a little bit more obvious example. See that big bag of worms? Shock. It turns out that when treated like VFib, these patients have a survival approaching that of actual VFib patients. That's good, rather than those of asystolic patients. Very, very bad. Finally, look at the function of the heart. The best way to do this is to eyeball how well the myocardial contractions are able to actually make that chamber size smaller, i.e. how much does the block get smaller. For example, here's a clip with very poor myocardial contraction in a patient with an organized electrical rhythm. There's a lot of fancy names for this phenomenon, like PEA, pseudo-PEA, or my favorite, old-fashioned electromechanical dissociation. But really, let's call a spade a spade. This is a patient in cardiogenic shock, so treat them the way you would treat a patient in shock. Use pressors that make sense for the patient's physiology, and don't just blindly push industrial quantities of epi every 3 to 5 minutes. Set them up as a drip and titrate until you can reverse or at least temporize the shock. I know that might not be a popular statement in pre-hospital medicine, but again, the reason patients who had this kind of pattern did much better with a drip and management of their underlying pathology than blindly following ACLS. So finally, how and when should we do this? Codes are inherently hectic, and we know that any pause in compressions precipitously drops the coronary perfusion pressure. And in 2017, 2 high-profile trials were published in Resuscitation that really drove home how much harm we could do by focusing too much on ultrasound during a code. They only had about 25 patients each, but they showed that rhythm check pauses with ultrasound were much longer than pauses without ultrasound. In the first study, this was 21 versus 13 seconds, and in the second one, they saw a paused length of 17 versus 11 seconds with ultrasound compared to no ultrasound. So if you subscribe to the belief that high-quality compressions are good and the cornerstone of cardiac arrest management, and also subscribe to the belief that ultrasound can help you manage these patients and improve their outcomes, this seems to be very bad news. So what do? Here's what I propose. Plan for your pulse check. Hopefully you all already do this, and pre-charge the defibrillator 30 seconds before the rhythm check. Add to this prep by placing the probe in the subxiphoid spot during chest compressions, and start looking for your window immediately. As soon as the pause happens, hit that Save Loop button. This will start recording a 6-second clip, and at the end of the 6-second clip, at which point,
Move! Get out the way! Get out the way! Get out the way!
just restart compressions right away. Look at the clip while compressions are ongoing, and look for those 4 things: activity, rate, rhythm, and function. And then, interpret that and be ready for additional interventions and the direction of the code. So today we talked here about identifying a pericardial effusion and thinking about this in trauma and in medical patients, identifying tamponade by looking for RV collapse, and remembering that effusion size does not necessarily mean the same thing as tamponade. We also touched on basic analysis of the heart during arrest, specifically being very careful when we define cardiac activity, separating out the electrical and mechanical function of the heart, and making sure that you're not killing the patient by wasting time on ultrasound. Thank you so much for sticking with this curriculum. There are some cardiac references at the very end of this video, but first I'll leave you with this little ditty from SMAC 2015 in Chicago.
And it might be time for us all to stand up maybe, because we're celebrating ultrasound today.
Do this? Oh, wonderful. Love it. Come on, guys.
Imagine there's no X-ray.
It's easy if you try.
No CT scanner.
And no MRI.
Imagine all the patients covered in jelly.
Imagine seeing their insides. It isn't
Hard to do. Nothing left to guesswork. No radiation to. Imagine all the patients being pain-free. You may say I'm a dreamer, but I'm not the only one.
I hope
Someday you'll join us, and the world will scan as one. Imagine no request forms.
I wonder if
you can. No need to leave the bedside. A brotherhood of sound. Imagine standing time, talking while you scan. You may say I'm a dreamer, but I'm not the only one.
I hope
Someday